Fertility Awareness Mastery Live is starting in July, and I can't wait to get started. This is my 8-week program designed to help you gain confidence using fertility awareness, and you are officially invited. Whether you're actively avoiding pregnancy or looking to optimize your cycles for conception, we have a spot for you. We start the first week of July. Are you ready to jump in? Head over to fertilityfriday.com/fam to register today. That's fertilityfriday.com/FAM. And make sure to join us before June 30th to take advantage of early bird pricing. This is the Fertility Friday podcast, episode number 315. Welcome to the Fertility Friday podcast, your source for information about the fertility awareness method and all things fertility. I'm your host, Lisa Hendrickson-Jack. I'm the author of The Fifth Vital Sign and the Fertility Awareness Mastery Charting Journal. I'm a certified fertility awareness educator and holistic reproductive health practitioner with nearly 20 years of experience teaching women to connect to their fifth vital sign through menstrual cycle charting, balancing hormonal health, and optimizing the menstrual cycle without hormones. I'm outspoken about hormonal birth control and its impact on fertility and overall health because you have the right to know how your body works and how artificial hormones disrupt that natural process. I host live coaching programs to help you achieve optimal fertility and health because it's important to have healthy menstrual cycles regardless of whether or not you want to have babies. I'm also a wife and mother of 2 beautiful boys. I know, I'm a busy girl, but I managed to fit it all in. This podcast is designed to empower you to take full control of your cycles, your fertility, and your overall health. And I'm so excited that you're here with us today. I'm excited to share today's episode with you. In today's episode, we are talking about abdominal therapy for infertility and period pain. And for those of you who've been listening to the podcast for a while, you'll know that this is a topic that I've covered in a number of different episodes, covering a number of different modalities, but really focusing on that concept of physical, visceral manipulation of the abdominal area to increase circulation, to reduce or eliminate adhesions in a non-surgical fashion, and the incredible benefits that can come from this non-invasive therapy, from fertility challenges to period pain, endometriosis, different types of conditions. And so we really get into it today. What I really appreciate about today's interview is the research that has come out of this modality and the incredible potential for healing the root cause with a non-invasive modality such as this one. So without further ado, let's jump into today's episode. And I'm really excited to welcome 2 guests to the show today, Belinda Wurn and Larry Wurn. So I'll go through and share their bios, and then I'll let them share a bit about their expertise. Belinda is the Director of Services for Clear Passage Therapies. She graduated summa cum laude with a BS in physical therapy from the University of Florida. And with extensive postgraduate work and decades of professional experience, she's considered an expert in the causes and treatment for various types of sexual dysfunction, including decreased orgasm, desire, arousal, lubrication, and satisfaction and painful intercourse. And Larry is the CEO of Clear Passage Therapies. He graduated from San Francisco State University with a BS in English and Creative Writing, and graduated from the Florida Institute of National Health in 1990 to become a Florida licensed massage therapist. Together, Larry and Belinda Wurn have developed the Wurn technique and Clear Passage approach, which is a non-surgical treatment for chronic pain, female infertility, bowel obstruction, and sexual dysfunction. So in today's episode, we are going to be talking about natural treatments for adhesions and how this can relate to fertility. So without further ado, welcome to the show, Belinda and Larry Wurn.
Thank you so much for having us.
Great.
Well, thank you for being here. Of course, I read through your bio, and the longer that you're working in the field, the longer the bio gets. So I'm sure that there's a few things that I didn't have an opportunity to mention. But maybe just share with us what inspired you to create the technique that you have? What inspired you to go into the realm of female fertility?
Okay. Well, I've been a PT since 1975, and in 84, I developed cervical cancer. And by the time they found it, it had spread toward my rectum, so they were scared to do a hysterectomy. So the physicians were very aggressive with me with external and internal radiation, and it killed the cancer, and I'm still here at 68, but basically destroyed my ovarian function and threw me into menopause at 33. And I developed what's called a frozen pelvis, where all my organs were glued together from adhesions. So I couldn't work for about 3 years. I had complex pain. I had intestinal problems, pain with sitting, pain with intercourse, sacrococcygeal pain. And I went to many, many different doctor specialists. And I got really tired of hearing, it's all in your head, or you have to learn to live with it. And that wasn't acceptable. So that started me on the path of studying any kind of manual hands-on technique that, different techniques that I'd read about in the weekly PT publications. And anyone that helped me, I started studying what they did.
So we were about to get married. I've known Belinda all my life. We were childhood sweethearts, and she was suddenly, a year after all this radiation therapy and surgery, she was just in debilitating pain, since doctors said we can't operate there, but those are adhesions, that's a very sensitive area. Vaginally, we would just cause more adhesions and more problems. So we started studying courses in the U.S. and also went to medical school in France for a while for some courses to learn how to treat adhesions and to develop adhesions, because there really weren't any therapies then, to develop adhesions for treating the female reproductive organs. When we came back and we started getting Belinda out of pain, and a year and a half later, she was working 40, 50, 60 hours a week and with no pain, when before she was in debilitating pain from adhesions. So we thought that was great. Decided to treat some patients with pain, and were very surprised when a patient came in. You want to take that one?
Yeah, so we opened our first private practice in 1989, and within the first year, it was in 1990, we were treating a woman who had a work-related slip and fall injury, and we were treating her for headaches, neck, back, and tailbone pain, and she had had a myomectomy. She had a fibroid removed from her uterus, so she had the horizontal bikini incision, and it keloided. It was really thick and bumpy and lumpy. So she asked if we would treat her scar while we were treating the rest of her, and we said, of course.
And sorry to interrupt you. For the listeners who are not physiotherapists, keloided, what does that mean?
Oh, a keloid is a scar that heals very lumpy, very bumpy instead of smooth.
Kind of sticks out.
It sticks out. It's thickened.
And is it painful, or is it just not nice to look at?
It's not nice to look at. I don't believe it's painful. So we said yes, we would treat the scar, and we treated her in the pelvic area. So she came in one day and said, Belinda, you're not going to believe what my doctor told me the other day. And I said, what's that? And she said, I'm pregnant. I said, that's great. Congratulations. And she said, wait, you don't understand. She had the HSG dye test done 7 years prior to our treatment, and she knew that both of her tubes were totally blocked, so she hadn't bothered using birth control. So it was a big surprise. So she went on and had a baby boy.
So to answer your question, I'm sorry, it's been a long way to get there, but it took several years to get to that point. But we realized we were opening blocked fallopian tubes. Physicians started referring some patients to us with blocked fallopian tubes, some without. They were just infertile. And most of them were becoming pregnant. We were opening their tubes. The chief of staff of the hospital called me in. He said, Mr. Wurn, I'm a surgeon. I've been a surgeon for 30 years, gynecologist and researcher. What is this about opening blocked fallopian tubes? And I handed him a half a dozen charts, and he said, oh my God. He said, you're doing things with your hands I don't think I can do surgically. And I'm a really good surgeon. And I said, is that okay? He said, well, yeah. He said, actually, it's really fascinating. Are you doing any research? No. Would you like to? Yeah, sure. So he said, why don't I be your research director? I won't charge you anything. I just think this is important work. And we'll start to develop some publications and see what all you're doing here and how useful it is for women. So we started, and we've now published about a dozen publications. In the most recent one, we treated, let me pull it up on PowerPoint. You may or may not have, well, here's a nice shot of some fallopian tubes that we had treated. Fallopian tubes ended up being easy to quantify because women would come in, and as shown on the left here, you can see a little straw going into the uterus. That V-shaped area, the large white area, is the inside of the uterus. And the dye goes no further than the little horns up there.
So for the listeners,
yeah.
What you're showing me is an image. So when a woman is having a fertility assessment, one of the tests that the doctors would perform is the HSG, which involves essentially putting dye into the fallopian tubes to see if it can actually pass freely through. So what we're seeing is an image of that, correct?
That's correct.
Okay, just so the listeners, I'm painting them a picture. I'm always thinking of the listeners, right?
Because it's audio, of course.
So this might be an image that we can have on the show notes page so the listeners can take a look through it. But essentially what you're saying is you teamed up with a surgeon who became the director for your research. And since then, you've been able to conduct peer-reviewed scientific studies that have been published to kind of lend credence to what you were seeing in your practice. Am I getting this correct?
Absolutely.
Yes.
Absolutely.
Yeah.
And so I'll just say one last thing for the listeners, because of course I've got a lot of keen listeners who've been listening to the show for a while. And so we'll make sure to link the publications to the show notes page so that the listeners can actually take a look at the research that you've done over the years.
That'd be great. That'd be great. Because in the beginning we were surprised and we said, how many do we need to treat to make sure this wasn't a fluke? And he said, well, ask the biostatistician. The biostatistician said, well, 6 would be good. That'll give us some indication, or 8. Well, the first publication we did on opening blocked fallopian tubes showed you had 28 women in it, and we opened blocked fallopian tubes, totally blocked, in 61% of them. And our latest publication, we've just had our 1,000th baby born, by the way, from Clear Passage.
Well, could we talk a little bit about what is happening here? So for my listeners, especially the listeners who've been tuning into the podcast for a few years, I've interviewed, as I mentioned to you in our pre-chat, a number of practitioners of different modalities. So I did an interview with a surgeon, an APRO technology doctor, who it's a different thing. He wasn't talking about unblocking fallopian tubes, but more so treating endometriosis and polycystic ovary syndrome and things like that. But I've interviewed a number of guests from different modalities, ranging from Arvigo therapy to fertility massage therapy to Mercier therapy, which are all different, but they have similar threads. They involve specific treatments to the pelvic area where you're actually going in and doing massage therapy or specific targeted treatment to those areas to increase circulation and movement and to remove adhesions. So could you talk to us a little bit about the physical aspect of your therapy? Like if a woman were to come to you, what's she in for?
Sure. Do you want to take that or do you want me to?
Yeah, go ahead.
Okay. So ours is a 20-hour program and it's based on science. I mean, it's one thing to be able to say, oh, we can do that and we can help. It is another thing to go through the excruciating task of actually gathering clinical research, having studies designed by physicians and biostatisticians, have them reading your studies and then developing and publishing results, and that passing peer-reviewed literature so that it's in the National Library of Medicine and the National Institutes of Health publishes it. So I just kind of wanted to set that in perspective. What we are doing, what we have always been doing, is treating adhesions. Adhesions are the internal scars that form whenever we heal. Thousands of tiny strands of collagen. They're very strong. They're like the strands of a nylon rope, but they're short. And they come rushing into any area where you've had an infection or a surgery or a trauma or endometriosis. Mm-hmm. And they lay down, they blanket the area, they become an internal scar. We started studying these because it was vital to us to save Belinda's life or lifestyle. And we hired a double PhD to examine what is it that we're actually doing that's opening these tubes, because we were just treating adhesions. And we believe that what's happening is where these strands are laying down, we are detaching them from each other, kind of like pulling apart the run in a sweater.
And how are you doing that? So are you physically touching the abdomen? Are you doing an internal procedure? Like, what is the procedure?
Well, it is all using our hands. It is very specific. We palpate the abdomen, well, anywhere in the body, but the abdomen and the pelvis for women with infertility or endometriosis or any sort of pelvic pain. We feel for where the organs are adhered or the tissues are thickened, and we apply a stretch, and we hold the stretch for a prolonged period of time until the adhesions gradually start to detach and deform and give way. So what we're doing isn't massage. We don't use lotion. We need the friction under our hands against the adhered organs or tissues to get the adhesions to give way. So it's as if we're very gradually peeling apart tissues and organs that are stuck together that shouldn't be. And as the organs and tissues can move more freely, pain symptoms start to get better and go away, and the organs can function more normally. It's like we're slowly peeling the straitjacket off of them.
Well, this is really interesting to me because I am not a body worker. And so I'm really fascinated just by the idea of, first of all, for a lot of women, getting into their physical bodies. Often when we hear issues of fertility or even issues of adhesions, we don't think to touch and manipulate the physical body. We think, okay, you need a surgical procedure or you need to take a drug or something like that. But share with us just a little bit about it, because I think I'm fascinated by the idea that you can actually palpate the abdomen and with your hands identify. So are you identifying where those adhesions are based on how your expertise and skill of feeling for those, and then physically kind of working those so you can actually feel where they are?
Yeah, absolutely. And, we work externally, but we also work internally, vaginally, and it allows us also to have a few glove fingers vaginally and our other hand externally, and freeing adhesions up from the outside in, especially on scars, and from the inside out. If a woman's had an abortion, any kind of a procedure to laser, to the cervix, for any skin, cervical cancers. But we definitely can feel where things, the tissues or the organs feel stuck or feel thickened or lumpy. And after we treat people, especially if they have scars, the scars look and feel totally different. They look flatter, and they're not so stuck to the tissues and structures underneath.
Well, and so not all modalities that are in this, say, category, use internal, let's say, touch or therapy. But in your case, you mentioned that you do. Is it something that you do in all cases, on a case-by-case basis, like sometimes? And then is it uncomfortable for the woman who's having it done?
Generally speaking, the physical therapists, they're all female physical therapists that we have working for us and highly trained in our certification process. They're pretty much all going to do an internal assessment at the beginning during the initial evaluation, unless the patient refuses. I don't think anyone has ever refused it because they want to get their goals met. Thereafter, we will treat internally as much as is needed. When you realize that you have an area that is warm, moist, dark, perfect for life to grow, you have things, women have objects coming into them from the outside world that may not always be sterile and clean. It is a perfect place for bacteria to grow. So you can get vaginal infections, subclinical infections, or clinical infections. And it's a place that gets traumatized from time to time. Rust, sex, abuse, athletic injuries, a fall onto your bottom, when you're roller skating, when you're a kid, or when you're a cheerleader. All of that can cause adhesions on the inside of the vagina and alongside the uterus and on the cervix, because that's where we heal.
Pelvic floor.
Throughout the pelvic floor. So often it will cause pain either with initial penetration or with deep penetration when your partner is hitting that cervix or hitting the coccyx. So we kind of need to be there in order to get all the results that some women need.
Mm-hmm. Well, and what's interesting about the work that you're doing, there's a few things. One is the application, so the different areas that this can help. So, I mean, of course, we're talking about fertility and the implications there. But when I introduced you, in addition to the fertility piece of it, we're talking about sexual dysfunction, improving orgasm, and I would imagine that there are also, you mentioned bowel obstruction, so also even some digestive issues. Could we go back then to the blocked tubes? So, as you know, when they have the test done, the HSG, and it comes back that their tubes are blocked, essentially the medical world says, that's it. There's nothing that we can do. And the only option that you have is IVF, and that's all. So I'm just curious. So it seemed as though in the first example that you shared with us, Belinda, I mean, you weren't setting out to unblock a woman's tubes.
No, not at all.
You were treating something completely different. So could you share with us then how, like, now that you've done the research and you've worked with however many women over the many years that you've been doing this work, could you describe to us how addressing adhesions in other areas then has this impact on the fallopian tubes? And also, when you were doing your research in these controlled settings, did you come across a more detailed explanation as to why this was happening? Like, why are the tubes getting unblocked?
Do you want to take that, or do you want me
Go
to?
ahead. Yeah.
Well, tubes generally block due to adhesions. And when medical profession told us that there's nothing you can do to open block fallopian tubes, but we were opening them and women were having babies, the chief of staff of the hospital got really fascinated, and we started doing some studies. In the latest study, we had 143 women whose tubes we opened out of 235. So it was a 61% success rate. The success rate was much higher than that if a woman had not had surgery on her tubes, because surgery does cause adhesions in that area. So the success rate is about 69% if they've not had surgery on their tubes, and about half of that, about 35%, if she has had surgery on her tubes.
And just to clarify, when you say surgery on her tubes, is that a surgical procedure to open the tubes?
That's correct.
Exactly.
And the results of having tubes attempted to be opened surgically is not great. What we found and studies show that if a woman has her tubes surgically open, she has a 6-month window within which to get pregnant. And if she's not pregnant within 6 months, the adhesions that form from that procedure itself block the tubes right back up.
Okay, I feel like I just want to hang out there for 1 second because I find that to be really interesting. So when you talk about your study, there was a different success rate had they not had the surgical intervention prior. So these are women who then had the surgical procedure to open the tubes, and the tubes closed back again, and it caused adhesions and made it more difficult to unblock. That's very interesting.
That's correct. I mean, these are organs that are designed to carry a single cell. They're designed to carry an egg.
Are they the size, so the diameter of a hair or something? Like, I remember, like, they're quite, obviously the fallopian tubes are quite small. Do you have a way to describe that for us so we can understand?
Yeah, well, they're tiny. They're designed to carry a single cell, a single egg, even though that egg may split into about 8 times by the time it's fertilized, or after it's fertilized. But it's about the size of a hair, and they're about 4 inches long. So it's tiny. And when you see an electromagnetic and electromicroscopic image of the inside of fallopian tubes, God, they're just beautiful. They look like a lush underwater garden.
Oh, wow.
They're absolutely gorgeous. A very vital organ.
Until they're blocked with adhesions, and then they don't look like the garden anymore.
Yeah, you're right. Yeah. I mean, the main things that block tubes, I mean, the most common cause is an infection or STD, chlamydia is one of the biggest causes. And, you have this infection that may start in the vagina, but it spreads and can and does go into the cervix and then spreads out into the uterus and out the tubes and ends up blocking them. So the main four things that create adhesions are surgery, trauma of any sort, like Larry described, falls, car accidents, or infections, or inflammatory conditions like endometriosis. So any of those things or a combination of those things can cause tubes to get blocked.
Mm-hmm. Well, I appreciate you for going through the reasons why, because it's very common, as we know, for the tubes to be blocked. And for some women, they may have had the chlamydia, for example, or another STI, and maybe they weren't aware that they had it. They were asymptomatic. And so, of course, that's quite a devastating shock to then learn later on that your tubes were blocked potentially for an infection you didn't even know that you had. Now I'm curious. So you kind of fell onto this observation by supporting a woman by doing a physical treatment for something completely different and discovering that it had an impact on the fallopian tubes because she got pregnant. And so now, after all of these years, do you have a specific treatment protocol that you follow then when you are targeting the blocked tubes versus previously or is it kind of a similar thing, like you're just addressing the general adhesions in the pelvic area?
Well, we can feel where we need to be. We have the patient's history. We spend hours going over patients' histories before we even accept them into the program, because we will accept a woman if we think we can help her. If we don't think we can help her, or we think there's a problem such as a cyst that is too large that or an endometrial cyst that we don't want to burst, we will turn her down. But so we've developed techniques, yes, over the years, over the last 3 decades, to specifically address fallopian tubes. And at the same time, we are addressing all the areas around the abdomen, pelvis, down into the leg, into the adductor, the inside of the leg, often the structures in and around the pelvis that are adhered.
Yeah, we'll work on the bladder. Many women have bladder issues, urinary stress incontinence. We'll work on different parts of the small intestine. I mean, you have to picture the pelvis and the abdomen. There's no space in between the organs. They're all crammed in there. So adhesions that can affect the uterus and the tubes, most definitely can spread and crimp or kink part of the small intestine, causing bowel obstructions. They can cause bladder problems. You have to picture this spider web of adhesions that can be sticking to anything and everything in the vicinity. So we treat whatever we find has restricted mobility.
And does your work extend to other conditions? I mean, I know when women have issues postpartum with following birth, they have uterine prolapse, often surgical options are presented to them. Is uterine prolapse and other issues that may arise post-birth something that you address?
We do see many people who have prolapses. We've been able to help them somewhat. If it's a severe prolapse, they may still require surgical intervention, but then, we encourage them to wait until they've healed for 12 weeks and then come to see us so we can make sure that things that got cut on don't become quite as bound down by the adhesions from the surgery. But we treat a lot of people. About a third of our practice is women with infertility issues due to different causes. About a third is complex chronic pain that people experience, men and women. And about a third of our practice is treating people with digestive, intestinal problems, bowel obstructions, things like that.
Well, and you mentioned sexual dysfunction as well. Did you want to take a few moments and share with us how this type of treatment can improve sexual issues? So what types of issues are women experiencing and how the treatment helps?
Absolutely. We were surprised when a woman called Belinda, and about 6 weeks after treatment, she was 45 years old. She said, anybody ever reported anything unusual to you? And Belinda goes, what do you mean? She said, well, it's kind of embarrassing. Okay, you going to tell me or not? Well, it's just that since I've come home, I'm having orgasms like I've never had in my life. These are real toe curlers. They were just so unusual, I had to report them to you. So this happened about 6 or 8 times. And Belinda had asked me, what should we do about this? And I said, look, don't even mention it. We're already the weird practice in town. We're just, but the chief of staff of the hospital got wind of it. He said, Larry, that's really important. We need to research this. And I said, we do? He said, yes, but there is a way to measure the 6 domains of sexual function. And as gynecologists, there's very little that we can do. We give desensitizing agents or painkillers, or we'll send a woman to a psychiatrist if that doesn't help. So we presented to the American Society for Reproductive Medicine and had the abstract published in Fertility and Sterility because we improved all 6 domains: desire, arousal, lubrication was a huge improvement, orgasm, including first-time orgasms, satisfaction, and pain. So I can give you that and give you that information, that graph for your website. But it began to show us that adhesions can form anywhere. They can form on the vaginal wall, decreasing desire and lubrication and orgasm, and causing pain in some women not. Some women just, the desire goes down or the lubrication goes down. So it was quite encouraging. When we presented at that conference, it was interesting that about 90% of the audience were psychiatrists because they thought that intercourse pain was all in a woman's head, and of course that's not where it is.
Yeah, I mean, we found that pretty much all of our female patients that had some pain with intercourse, we found that the cervix was very adhered. There are 4 ligaments that attach to the uterus, to the cervix. It's the most fixed point in the female pelvis. And all of those ligaments need to be elastic, like stretching a rubber band. And if any of the ligaments that attach to the cervix are adhered, the cervix is not able to move out of the way during intercourse. So it hurts. When their husband's penis is hitting their cervix, that doesn't feel very good, especially if they're trying to get pregnant. It's not great if you have pain with intercourse. But we found that by freeing up adhesions affecting the cervix and the vaginal wall, that pain with intercourse significantly decreased. And we resolved it in 90%?
Yeah, it was
a very high percentage
for
decreasing sexual pain.
Well, and one of the questions I was going to ask you, which you just alluded to, was that what is the function that is allowing this to happen? So what is happening physically in the body that is improving a woman's ability to orgasm and lubricate and reducing the pain? And when you described the cervix, and one of the topics that has come up in similar, it's not similar because I know each modality is different and has its own unique aspects of it, obviously. But one of the kind of common threads that has come up in these types of discussions is just that we consider the uterus as dynamic. As women, we see a picture of the uterus. It's inside us. We don't really interact with it. And we often just think it's a stationary organ. So my area of specialization is the menstrual cycle and menstrual cycle charting and fertility awareness. And so identifying when in your cycle you're fertile and when you're not. And one of the optional ways to identify that is through checking the position of your cervix. And so when you start to understand the cervix, it's the lower part of your uterus. But throughout your cycle, even just hormonally, so outside of sexual function, your uterus physically moves. And the cervix is pointing in different directions at the different points of your cycle based on your hormone levels. Yeah. So in order for that to happen, you need, your uterus needs to have freedom of motion. Yeah. And so what's really interesting is addressing the physical aspect of orgasm by removing the adhesions around the cervix so that the uterus can actually freely move during sex. I think that's really profound.
Yeah. Well, the uterus absolutely needs to be mobile. There are 6 ligaments that attach to the uterus. The broad ligaments run along both sides of the uterus and attach to each of the pelvic bones. And the round ligaments go from the front of the uterus, run through the groin, and attach next to the labia majora at the level of the vagina. And then we have 2 uterosacral ligaments that go from the back of the cervix to the tailbone, the coccyx. So all 6 of those ligaments need to not be adhered. And in order to have an orgasm, what physically happens is that the vaginal walls narrow and the uterus becomes more vertical and moves upward in the pelvis. And if that uterine mobility and the uterine walls are adhered, it's hard or if not impossible to have an orgasm because all those physical motions are vitally important.
I just wanted to pop into today's episode to remind you that early bird registration is now open for Fertility Awareness Mastery Live. This is my 8-week group coaching program designed to help you unlock the secrets of your menstrual cycle. Fertility Awareness Mastery Live teaches you everything you need to know about fertility awareness cycle tracking to achieve your intentions. Whether you're currently trying to get pregnant, avoiding pregnancy, or planning to conceive in the future, we have a spot for you. Head over to fertilityfriday.com/BAM, that's FAM, to reserve your spot today. So again, that's fertilityfriday.com/BAM. And you have until June 30th to sign up at the early bird price. Now let's jump back into today's episode. Well, there's something else that you said that, of course, I want to touch on. So one of the areas that I've talked a lot about on the podcast over the years, and that's not what we're talking about today, but I am going to just take a mini tangent, is birth control and how it can impact libido. You mentioned that in your conference when you were talking about the way that you have improved women's sexual function and the 6 points of around orgasm that you were describing, and you were in a room full of psychologists who were kind of under the impression that there's this emotional thing. I just felt that similarity to that because there's a lot of reasons why women may experience sexual dysfunction, and it has nothing to do with like a past child trauma. Like it could be related to something like a physical adhesion in their pelvic cavity. And I think for a lot of women listening, especially women who may have experienced difficulty orgasming, low libido, pain with sex, I feel like this information is vital so that you can kind of understand that it could be related to a physical issue like any other, health condition.
That's right. I don't know what else to say. That's absolutely right.
Yeah.
I'm curious, did you get any interesting feedback from the psychologists?
Well, they were shocked. They were shocked to hear that there was something going on, that women didn't want to have sex for some reason other than it was all in their head. I got a lot of questions afterwards from them, some of whom were asking about opening block fallopian tubes. And we're really getting, because the psychiatrists have all been through med school, so they could understand, there are mechanical attachments there. And yes, adhesions can form anywhere. So the dawn is starting to launch for them to be able to see that. So the ones that went to med school, especially, I think, got a lot more out of it than the psychologists who were going, really? Well, I think it was interesting to all of them.
Well, and it's so interesting because, after you've said it and after we've had a conversation about it, I'm sure the listeners are nodding their head because it's kind of like, of course, when you have an orgasm, the orgasm is not in your head. Like it's a physical thing that you can feel, like you can feel the contractions or I don't know if it's a contraction, but you can kind of feel the pulsing of your cervix and vagina, like it actually physically contracts. So it is an orgasm is a physical experience. Absolutely. So it's kind of ironic that we would think that the sources of an issue with orgasm must be emotional when it's a very, like anyone, like if a male ejaculates, that's not in his head. Like it's a physical thing, semen comes out. It's obviously a physical reaction, but I think because as women, our clitoris, the vast majority of the clitoris is located internally. And so I think, we kind of minimize the physical nature of a woman's orgasm and sexual function because we don't have a huge penis sticking out, right?
Right, exactly.
This is really valuable. And I think the work that you're doing is really incredible. The question that came to mind is, okay, so you've been at this for a really long time, obviously. You had the good, I don't know if it's good fortune or just you just have good friends, connections, professional connections to be able to do research on the techniques that you developed and to be able to do peer-reviewed research and controlled studies. A lot of the practitioners of, I would say, like in the category of this type of modality, which would be physical manipulation of the pelvic area to reduce adhesions and to improve circulation. A lot of the practitioners that have been doing a similar type of work, so in the same category, don't have access to the resources that you've had, and they don't necessarily have the ability to produce studies to verify the results that they're seeing. So now that you've kind of, you've done this work for the average woman, and I think that you've experienced this quite a bit, the average woman still doesn't know, and your average physician probably doesn't know. What's your vision? I guess what I'm trying to ask the question in a certain way, but how do you see this knowledge, this very important knowledge, getting into mainstream medicine?
Well, I think publishing studies is absolutely vital. And it's just backing up for a second. It's not that we had friends or that it was easy doing research. No, we had to go out and hire PhDs and hire physicians or gather physicians that were interested and then hire a double PhD to do the work and biostatisticians. So that capability is open to all of these other modalities. They have and they may be great and they may not be great. We just don't know because we don't have the science out there. So I would encourage them to go out and hire some PhDs and to find out what is your actual percentage of success rate? How do you even measure the success? And so that you can look people in the eye and say, this is what we can do. This is what our studies have shown. This is what independent researchers have shown can work. So that's available to anyone. It was a whale of a lot of work.
Takes a lot of time, a lot of energy. And we like to treat people. That's, we don't do research. We hire people to do it.
Would you mind hanging out there for just a moment? I mean, I have a lot of practitioners listening and people of different modalities. So from your experience, it's a lot of work and having to go and do all those things yourself. But I think what I hear a lot is that research would cost millions of dollars. And, we're just a small organization and we don't have the funds to be able to put together these studies. So there's this idea that in order to do research, you have to have tens of millions of dollars even to conduct one study. So for those practitioners who are in that space, you're saying that it's possible, which is amazing, just for someone to say, okay, look, it's possible. We did it. You can do it too. But what would you say to the person who says, I'm not a big corporation. I don't have millions of dollars. How could I ever do research myself?
Well, we're not a big corporation with millions of dollars either. There's something
we're
called
small. Yeah.
The chief of staff at the hospital and scientists that we talked to explained to us there's a scientific method where you start seeing results, you gather data, you keep your data, and you need to kind of look at it, and then you can do a single case study, a single retrospective. Oh, this is interesting, this happened. It's called anecdotal, but you can still publish that. It may cost you a few $100s to have it published at the publication, but you can publish that. Then you can do a multiple case study. You have multiple cases. If you have before and after images or before and after data, then it starts to become really interesting, because if you can get 10 or 20 of those, then you have a pretty good pilot study. You can publish that, but it's incumbent upon the practitioner to keep his or her data and to start gathering that, and then to write it up and submit it, or go to a place where they do have medical writers and hire medical writers. It may cost you $1,000 to have the study written up by somebody who is a physician, is capable of doing it, and it may cost you an extra $1,000 or $1,500 to have it published. But if it's that important and that breakthrough therapy, you got to go there. So maybe you charge a little bit more in order to be able to publish. So and then you go on from retrospective to prospective studies, and then to controlled studies. So there's a scientific method. So that people should look up the scientific method, but they should start keeping their data and think about their case studies that they can publish.
Well, you know what? Thank you for sharing that. I think that often with anything, it doesn't have to be a scientific publication. It could be with starting to go to the gym. I don't know. But we always think that we always go to the most difficult and think, this is impossible for me. Mm-hmm. And what you basically described is starting where you're at and finding a way to track your data, doing your own research to find out what would be the most scientific way for you to track your data, starting with what you have and building on that. And yeah, a couple $1,000s might sound scary to somebody, but a couple $1,000s is not a couple million. And so what you described is, I'm sure it's still really obviously very difficult and very time consuming and probably not what you want to be doing when you're a practitioner. But at the same time, it means it's not unobtainable. It means it's not impossible to.
Yeah, it's step by step. Start small and gradually getting bigger over time.
Yes.
You may be able to find some of these providers may be able to find a PhD who will write the study for free just to be able to be named on the study.
Yes.
There you go. So that's another thought for it.
Mm-hmm. Well, so I mean, we've gone into quite a bit of detail just to kind of touch back to our conversation about how this physical procedure can impact fertility. Is there anything else that you wanted to touch on? Any other aspects of the treatment and how it relates to fertility that you want the audience to know?
Do you want to do that or you want me to?
You go ahead.
Just this. We started out treating adhesions. Adhesions form anywhere in the body. The fact that they form in the female reproductive tract, yes, we've been able to track the fact that improves fertility in a number of different ways in women with endometriosis, PCOS, blocked fallopian tubes, even hormonal infertility. We were very surprised with the high FS women that have been declared hormonally in menopause that have become pregnant and then become pregnant again. We published on that as well. Fact that if you have adhesions that are affecting your fertility, adhesions do not only affect the reproductive organs, so they will pull you forward. And if you feel like, gosh, I'm pulled forward, I'm short, and my back is getting tight, my neck is getting tight because it's fighting all the time to get me up straight. So getting those adhesions treated and released and freed up improves your general overall health and your quality of life immensely and measurably. We've measured range of motion improvements and published those as well. So the fact that it affects sexual function, we weren't really trying to open blocked fallopian tubes or improve sexual function. We were just trying to get people out of pain and decrease adhesions, and all of these things came. So when you have a therapy that addresses adhesions and addresses them effectively, the quality of life issues that can improve as well as fertility can be profound, especially in women with significant surgical history or with endometriosis.
Mm-hmm. Yeah, I feel like that really sums it up. And it's not very often that I don't have a lot to say, but I really feel like what you said was really powerful. So, I just want to thank you, Larry and Belinda, for coming on the show and sharing your expertise. I know that a lot of our listeners are going to kind of head right over to the show notes page and look into your research and look at the different studies that you've published, because that's one of the challenges with this area of female reproductive health, where there are many modalities that are doing similar things and kind of trying to get the word out there, and often completely rejected because there's no science. And one of the things I always say is that if a research study hasn't been done on that particular protocol, it doesn't automatically mean that the protocol doesn't work. It means that the research hasn't been done. And right. So it's really inspiring that you went out there and did that research to now lend credence to abdominal physical therapy modalities aimed at removing adhesions to improve. And again, as you said, it wasn't, your intention initially was not to improve fertility. It was to improve general health and reduce pain and those types of symptoms. So thank you so much.
Sure. If just as a coda on the end here, if someone is interested, wants to learn more, our website is about 500 pages. It's full of information. It's designed to inform a person. So if they feel like it'll help them, they can click a little button and apply for therapy. We'll see if they can qualify and see if we can help them. So that's at clearpassage.com. We've also authored a few books. The most recent one is really a consumer book called Adhesions, the Body's Internal Menace, something to that effect.
Hidden Menace.
The Body's Hidden Menace. We made it available for 99 cents, I think it is, on Kindle. So it'll give a lot of information on adhesions and how they can affect not just fertility, but the entire body. But there's a good section on fertility. And if someone is interested, they can apply. We'll go through their history. We don't charge a cent for that. We spend a long time going through their history. Maybe we even want to talk to their physician if that's okay with them. And then we'll we'll give them some good information, let them know if they're appropriate. And then we don't push anybody. They decide for themselves if they'd like to come in. Therapy generally is a 5-day treatment. People fly into one of our locations on the weekend. We start Monday, get 4 hours of therapy a day, Monday through Friday, and they're done Friday afternoon. They can go home, fly home on Saturday. So, and all of our research, all of our published research is based on that 20-hour program. So there it is in a nutshell for you.
Well, so again, the website is clearpassage.com. We'll link to that in the show notes page, as well as the book that you mentioned. A week straight, 4 hours a day sounds like quite an intensive treatment. So that's very interesting that you have it designed in that way. And so for the listeners, I think I said it in the bio, but where are you located physically?
Our home office is in Gainesville, Florida, and we have trained therapists to do the work that we do. And so we have 2 therapists in London, 1 in Canterbury, England, 1 in St. Louis, one in Manhattan, New York City, with therapists on the West Coast in Encinitas, that's north of San Diego, 1 in Beverly Hills, LA area, and 1 in Oakland in the San Francisco area.
Okay, so you're gradually doing like a takeover.
We're slowly starting.
we're a small
you'll get there.
Yeah.
We need to find a therapist. We need to find physical therapists with fabulous manual skills before we'll treat them. So that's why we're growing slowly.
Okay. Because you're looking for the people that already have the skills so that you can teach the correct procedure, but they're already skilled in the physical therapy realm.
Yes.
Well, you never know who could be listening. So we'll just leave that right there. Well, thank you so much for being here. I really appreciate you taking the time to share your experience and your expertise. And I think that, yes, what you've done in terms of putting together the research and getting the word out is very inspiring. So I do appreciate your time today.
Thank you for having us. We appreciate it.
Thank you for listening. If you enjoyed today's show, please share it with a friend. You'll find the show notes page for today's episode over at fertilityfriday.com/315. I hope that you enjoyed today's episode. I just really love having the opportunity to talk about this abdominal therapy modality and really encourage all of you who are listening to think about the physicality of our bodies. I think it's really interesting how detached we can be from our bodies, where our medical system has kind of trained us to always look for a pill or a supplement or something like that to resolve physical issues that can also be significantly improved by abdominal therapy, actually addressing the area, thinking about the physicality of our uterus. Where is it located in the abdomen? Could there be adhesions? Could there be ways to physically manipulate the area to improve the circulation and blood flow and lymph flow, and to realign and to break up adhesions without having invasive surgery? So if this topic interests you, if this is the first you've heard of it, or if you've listened to the podcast for a while and you haven't tuned into a few of the previous episodes that I did on this topic with different modalities, make sure to head over to the show notes page. So you'll find that at fertilityfriday.com/315, where I will list out the different modalities that I've covered on the show that address they address the same thing in different ways, but it's essentially a very similar concept of actually addressing the physical part of the body through abdominal therapy. And I mean, what an important part of women's healthcare that's essentially missing from our medical model, right? The concept makes so much logical sense to actually address that physical area, and the numbers speak for themselves. So in each of the interviews that I'll list on the show notes page that I've done previously, these practitioners have a lot of experience, in many cases specific scientific studies that have been done, and a lot of positive client results. And so the way I look at it is, imagine if we lived in a world where instead of going straight to drugs and surgery, we actually looked at modalities like this first. as the first port of call because it's the least invasive. And imagine if we really treated the body as capable and knowledgeable and thinking, okay, well, if there's a problem, maybe we just need to improve the blood flow, circulation, break up some adhesions. What if that was the first thought when we were addressing some of these conditions? So, I mean, I definitely do hold a much needed and positive vision of the world in my mind. That's why I continue to do these podcasts. So thank you so much for tuning into the show. If you know somebody who you feel would benefit from this episode, make sure to share. So fertilityfriday.com/315 is the link. And thank you all for being part of the Fertility Friday community. This podcast continues to grow, and more women and men and health professionals continue to learn about the podcast because of you, because you continue to share the episodes and talk about the episodes. I love seeing you tag me on social media and sharing. And so thank you all for being part of the movement, part of the community. And of course, as always, until next time, be well and happy charting.